Hello, good afternoon, and thank you for joining me. I want to spend the next hour going over what has become an absolute passion in my life, and that is the treatment of dental sleep medicine. Um, while while you may or may not know, not only am I a dentist, I'm also an attorney. And you might ask, well, what's the dentist attorney doing, treating dental sleep medicine? Well, first you have to understand how serious that condition is. I really didn't understand until my dad died of a stroke in the middle of the night. I'm sure that was probably a coincidence, but my grandfather died of a stroke in the middle of the night. You put two and two together, and considering that both my grandfather and father looked exactly like how I look right now, you become very motivated to learn as much as you can about this condition. And over the last several years, not only have I developed a flourishing dental sleep medicine practice, I've been allowed to help shape some of the protocols and some of the parameters that we're actually using now in dental sleep medicine. So we're going to discuss all of that with the depth that we can in an hour. But more importantly, I'm going to explain why you have to become familiar with dental sleep medicine. It's no longer an option. So we're going to learn why you must do this. So again, let me tell you a little bit about myself. The only thing really on qualifications that's probably worth talking about is I've been a dentist forever, probably longer than some of you have been alive. I'm also an attorney. I graduated from law school in 1995, and I'm a diplomate of the American Board of Dental Sleep Medicine. So anyway, let's talk about some disclosures. I'm very excited the fact that March the 8th, my textbook, and it's really not a textbook, it's more of a handbook, was published by Quintessence, and it's now available. So I all of a sudden in my professional career, I guess I'm now a book salesman. So, but anyway, there you have that. Also, yes, that's me on the top left-hand side. I'm the president of the dental sleep apnea team. These three young ladies that I get to work with every day are the leading experts in billing and insurance and team education and training for the implementation of dental sleep medicine. Down here right below me, that's Jan Palmer, who is on the Medicare Educational Committee. Beside her on the bottom is Glenine Varga, who is a guest speaker at Spear and Pankey and all over the place, and absolute team trainer. And the good-looking young lady to my left is my wife, Patty, and she's been billing for dental sleep medicine and TMD for, gosh, 20 years now. So I'm really blessed to have the team that I work with. I want you to know I'm not giving legal advice. Obviously, I'm sure there are people on this webinar from numerous states, and each state has their own set of laws, and they may not be exactly in line with what I'm saying. So, if you do need legal advice, please contact an attorney in your state. And if that attorney needs help, have him call me. And nothing that I say has been approved by Cat and Bob. So let's talk about sleep disorder breathing. And obviously, I have no idea of the people that's on this webinar, and I really don't know where you're starting. So I'm going to assume that you know little to nothing and try to fill in some of the blanks. Sleep disordered breathing is this universal term for a collective group of disorders, and it starts with simple flow limitations where patients are not getting a full breath of air at night, all the way up to frank obstructive sleep apnea, where patients are literally, their airways are totally blocked off at night, up to Cheyne-Stokes respiration and central apneas. So when I use the term sleep disorder breathing, I'm using it collectively. But what I really want to point out on this slide is that of the older adults in your practice, a minimum of 60% of them have sleep disordered breathing. And by elderly population, I mean people over 40. So if you look at the demographics and look at your practice, you can quickly figure out there is a huge potential in most people's practices to develop a dental sleep medicine practice. Especially if you're like me, getting a little older and thinking about retirement, or thinking about at least hanging up the handpiece and doing something else. Dental sleep medicine is a great way to extend your practice, because it is in many ways just like ortho. It is primarily driven by your staff. So a great way to extend your practice. So sleep disordered breathing, if you look up on top, and sleep related breathing disorders, those are the same thing. I hope I don't use those terms interchangeably in this lecture, but basically anytime I use either one of those terms, I mean the collective group of disordered breathing. And it's this general umbrella term, and primarily the people that have sleep disordered breathing have an ability or have some extent of daytime sleepiness, along with a decreased ability to function during life. Many of these people are sleepy. Frequently, these are the people that will have wrecks and fall asleep while driving. And so they present not only a danger to themselves, but a danger to innocent bystanders. So it's really, really imperative that we find these people. Now, I need to apologize in that we have had some trouble with the sound on the videos that I have. And I'm about to show you a video in a few minutes of a patient that has sleep apnea. So I'll have to explain what's going on in that, because our sound is messed up. But anyway, we'll work through that. But anyway, don't freak out at this slide. This is me trying to come up with a relatively easy explanation of the continuum of sleep disordered breathing. If you look at the top left, you have obviously a baby that's asleep. The mouth is closed. Baby's breathing through his nose. He's not making any noise, any sound. That's literally how we're supposed to be breathing at night when we sleep. But once a child or adult starts making noise, any noise made during sleep when the patient is trying to breathe is the start of sleep disordered breathing. As the resistance to breathing increases, at some point you begin to have what we recognize as frank snoring. Now, everybody's definition of snoring is different, but as the intensity of snoring increases, as the resistance increases, at some point you get what we call RERAs, or respiratory effort related arousals. Now the effort involved in breathing, the effort involved in snoring is now causing the patient to arouse, not necessarily awaken, but arouse from a deeper level of sleep to a lighter level of sleep. That fact alone can start resulting in different comorbid diseases such as daytime sleepiness and hypertension. As the RERAs and the snoring increases, we now have what is diagnosed as upper airway resistance syndrome. Everything from upper airway resistance syndrome down to the noise, these are not areas that there is insurance coverage, because all of that is basically considered snoring. And snoring has not been found to be a medical condition that the insurance companies are willing to pay for. So any patient that is tested and is found to have any one of these conditions, from upper airway resistance syndrome down, those patients are a cash pay. Once the patient starts having apneas and hypopneas and apneas and central apneas, now medical insurance companies kick in, Medicare kicks in, and these patients are considered severe enough that medical insurance will compensate for the treatment to some degree. As the seriousness continues, obviously the comorbid diseases continue. Sadly, many of the conditions that end up resulting from obstructive sleep apnea, as you can see, contribute to the death of the patient. My dad died of a stroke in the middle of the night. That's not supposed to happen. So anyway, I think the next thing is our video of a patient with apnea. I apologize, but here we go. Anyway, he is breathing right now and making very, very, very interesting sounds. And if you'll watch right here, he obstructs. Notice the two belts around his waist. They're not moving. He's actually in what we call a mixed apnea. Now you start seeing the respiratory effort. He is not snoring. There is no sound. There is no air actually going into his lungs. It is an apneic event. Eventually, the carotid bodies in his carotid artery will actually increase respiratory effort, and now he breathes. Okay? We will make these videos available on the Catapult website, and they'll send this out to you in the future. That's what an apneic event actually looks like. So what you have is a cycle where you have sleep onset, okay? That's where the patient is actually now asleep, and with that, you get decreased muscle tone and collapse, or at least partial collapse of the airway. As the airway is occluded, you get elevation of CO2 and a decrease in oxygen. All of that results in a signal in the carotid bodies to increase ventilatory effort. As effort increases, eventually the brain results in an arousal of that patient. You get the relief of the obstruction, and the system just starts over and over again. So what's the problem with all of this? Well, the problem is that when you arouse, every time you go through this, you're actually getting a cortisol release. You're getting the fight or flight response. You're getting increased blood pressure. You're getting increased respiratory effort. And more importantly, you're getting increased heart rate as a result of each one of these events. This is what it actually looks like on a sleep study. Now, I know there's a whole lot here, so don't freak out on me. What you can see here is the body position of the patient. He's on his back. This is activity level. This is how much movement is going on. This is the amount of airflow that the patient is getting. So these are gasping breaths. Then the airway closes down, and this is the period of time that there is little to no air that the patient is getting. Then you're getting a gasp and the same thing, and that repeats itself. Under that, you see how much oxygen desaturation that occurs with each one of these events. You can also tell how long each one of the events were on some of them. Here you see the SpO2 or the oxygen desaturations associated with it. So each one of these results in a sympathetic spike. The problem. October 2017, the ADA released a policy statement on the dentist's role in the treatment of sleep disorders. Actually, starting this September, I lecture at the ADA National meeting. I do a 2-day lecture on the policy statement and how dentists have to screen and basically what you need to do to get a dental sleep medicine practice going. But once the ADA published this policy statement, states are now beginning to line up to pass a version or a very similar version of this ADA policy statement. My best guess is that within 10 years, maybe less time than that, every state in the country will have adopted this ADA policy statement. In fact, right here in front of my desk, I've got North Carolina's version of this, and that is about to be approved by their board. Delaware is adopting this policy statement verbatim. North Carolina is recommending continuing education hours every year if you're going to do this. So anyway, this ADA policy statement is about to be part of your world. Now, why is this so important? Well, every time the ADA adopts a policy statement, plaintiffs' attorneys, they're very aware of these policy statements. In fact, back in 2010, the ADA adopted the policy statement on intraoral screening for cancer. Now we have lawsuits each year for patients that weren't screened. So starting right now, y'all need to start screening and document in your record that each patient was screened for sleep disorder breathing. So let's see what that policy statement says. First thing it says that there are the disorders is characterized by disruption in normal breathing patterns. It's a potentially serious medical condition causing collapsed airway. Sleep disorder breathing includes snoring, upper airway resistance, obstructive sleep apnea. It's associated with cardiovascular and respiratory and dental and other diseases. And it's also very much involved in the growth and the learning patterns and behavior patterns for children. Dentists do play an essential role. We're supposed to work in conjunction with our MD colleagues, and we're going to discuss that more in here in just a minute. Children are very much affected by sleep disorder breathing, and most people don't know that. Many of the children that have been diagnosed with, I call it the alphabet diseases, the ADHDs and the ADDs, those children that have been diagnosed with hyperactivity conditions, many of them actually have sleep disordered breathing. That can be due to tonsillar hypertrophy all the way up to non-productive suckling with pacifiers and sippy cups, all of these things that cause arch collapse. But anyway, we're supposed to be screening not only adults, but children. The policy statement basically says dentists are encouraged to screen patients for sleep disordered breathing. By encouraged, the law or the lawyers will interpret that to mean a reasonable and prudent practitioner would screen all their patients. You screen them based on sleepiness, choking, snoring, witness apnea. We'll go into that in just a minute. But primarily, the easy way is to look for obesity, class 2 bite, hypertension, and other medical conditions. Once you identify these patients, they should be referred to an appropriate physician. And most people interpret appropriate physician as a board certified sleep physician. Now, I do understand there are some people that do not have sleep physicians across the street like I do, but you need to find those people to refer to. Children primarily should be screened through a medical history and clinical examination. They're a little more difficult to screen because they really don't necessarily present as an obese child, although they can present that way. But many of these kids just are not thriving. They're simply not doing well in school. Again, the hyperactivity disorders, many of them have very, very large tonsils. So let's look at what we can do with some of these kids or with some of the screening. First thing, you need to modify your health history and look for not only the comorbid diseases associated with OSA, but what's the patient's height and weight. You can quickly do on the cell phones these days, you can look up their BMI very quickly. And anyone basically over a BMI of 30 probably has better than a 50-50 chance of having OSA. If it's over 35, it's probably a 75% chance. A simple question like, do you snore? Okay. Do you ever wake yourself up gasping for air? Have you been diagnosed with OSA? Do you wear a CPAP? Okay. Or you probably need to say, have you ever worn a CPAP? Because many patients, their CPAP is in the closet. But simply looking at your health history and looking for patients with a history of high blood pressure, diabetes, stroke, GERD, and cardiovascular problems. If a patient has high blood pressure and they're taking 2 medications to control that high blood pressure, there's probably an 80% chance that patient has OSA. Again, if they have had a stroke, there's better than an 80% chance they have OSA based on that stroke. So just simply changing up your medical history and looking for the comorbid diseases that are associated with OSA, you will find a bunch of these patients. Additionally, there's some screening questionnaires that we use. The most common one is called the Epworth Sleepiness Scale. It has 8 different situations: sitting and reading, watching TV, inactive in a public place, passenger in the car, lying down to rest, sitting and talking to someone, sitting quietly after lunch, in a car while stopped in traffic, and 0 to 3, your chance of dozing. Obviously 3 being a high chance, 2 a moderate chance. Well, anyway, the patient fills this out and you add up the score. First thing you need to know, patients will lie to you on this thing. Unfortunately, they do it all the time. But historically, the number of 9 or higher has a fairly significant chance of showing that the patient is excessively sleepy. Now, the problem is excessive sleepiness can come from a bunch of things, not necessarily just OSA. The patient could travel a lot and be jet lagged, so you have to understand that each one of these screening documents has limitations, but the Epworth is used universally throughout sleep medicine and is a common number that you'll see on many of these patients. The gasp sleep questionnaire. Again, you're asking different questions. Have you been told or do you know that you snore? Do you struggle to breathe when you're asleep? Do you feel tired, fatigued, or sleepy? Do you have acid indigestion or high blood pressure or use medications to control these? Are you overweight? 4 or greater is a high risk. Again, a good way to catch a number of people. The one that's probably used the most is the stop bang questionnaire. The stop bang, you go in and find out the age of the patient, the height in inches or centimeters, the weight. Obviously, you're looking for the BMI to put this in. Are they male or female? Collar size. This is easier for men than women. In our office, we make sure that we measure each one of our patients' neck. If the patient is a male and has a neck size of over 17 inches, there is a large chance, a huge chance that that patient has OSA. If they're a female, the number is 16 inches. So, but anyway, the stop bang is S, do you snore loudly or louder than talking or loud enough to be heard through closed doors? Yes or no. Do you often feel tired? Yes or no. Observes, has anyone observed you stopping breathing during sleep? Yes or no. High blood pressure. BMI. The stop bang uses 35. I think that's a little high, but this is not my questionnaire. Age, are you over 50 years old? Neck circumference, 17 and 16 inches. We mentioned all of that. And gender, are you male? Well, if you answered yes to 3 or more of these items, there's a very good chance that you have OSA. So, if you modify your health history, start asking some simple questions, potentially put the Epworth Sleepiness Scale and the Stop Bang questionnaire in your new patient package, you're going to catch a whole lot of patients that have OSA. Now, what do you do with them? Protocol says you refer them. You refer them to a sleep physician. Write a simple little letter introducing the patient, that you screen them based on an Epworth, and the patient had an Epworth of 18, which is obviously high, and a positive stop bang questionnaire, and you would like the physician to evaluate them. That is literally all you have to do. Now, once you do that, obviously you need to document in your records that they had a positive screening for OSA and follow up with that patient to make sure they actually went to the sleep physician, because many patients will not go because they are afraid of CPAP. They just do not want to wear the CPAP. So it's really important that you or your staff becomes very, very conversant in OSA. At some point, if you're not already, you need to become aware of the appliances we can make and how we generally go about making them. And I'm going to show you some of that in just a minute. But you need to reassure the patient, if they do not want to wear CPAP, that you can fabricate for them a mandibular advancement device, which should be able to help them with their OSA. So we're going to talk about that. You send the patient to the sleep physician. Eventually, he's going to start referring them back to you for a mandibular advancement device. A mandibular advancement device, you can think of it as an upper and lower hard acrylic night guard type of appliance with some type of mechanism between the upper arch and the lower arch that advances the lower arch. And as it is advanced, the tongue comes off the back of the throat, it opens up the airway, and it results in decrease in snoring and decrease in obstructive sleep apnea and hypopneas. Well, the reason why Catapult was gracious enough to sponsor this, I absolutely love their materials. I love their airway metrics device, and I use those daily to fabricate my appliances. So anyway, my favorite, obviously, for taking the impression is the Panasil Putty Soft and the light body material. And I actually swiped some slides that I've used for a while to show how we're doing the putty wash technique. Again, here's the putty and the light body. And obviously you take a full scoop of the base and the catalyst, okay, and you start mixing that, and you mix it into this, hot dog weenie shape. And here we're actually using an Invisalign tray, but you actually go in and put that weenie in the Invisalign tray, pat it down. Obviously the palate's not really important here. And if you're doing this putty wash technique, obviously you need room for the light body. So in this particular technique, you're actually using a Glad cellophane bag. You put the bag over the putty, then go in and go to the mouth with that. Well, obviously you pat out a little place here for the teeth, but you go to the mouth with that, take your initial impression, and the plastic bag results in a less than good impression, if you will. Now, the one thing I would like to caution you on this technique, if you look at the material once you're through, obviously you want the material to extrude through the tray so it's locked in well. But if you look at the occlusal part of the surface, if you look at this area next to the second molar, it's really important that you get some material distal to the posterior molar. Mandibular advancement devices put a lot of pressure on the teeth. And if you don't get the distal aspect of the upper second molar and the distal aspect of the lower second molar wrapped with the appliance, you'll start getting some tooth movement and spacing and that sort of thing. In this particular example, I don't think the distal aspect is, in particular here, is wrapped quite enough. But anyway, I'll show you how that comes out. Obviously, we go in and put the light body into the impression and go right back to the mouth. Obviously, this time with the light body in there. You let that sit. I'm very, very, very careful to make sure that I don't pull these too fast. But anyway, once you let it sit, you get a really, really nice impression, except notice, I hope you can see my arrow. Notice right in here where the margin didn't quite get picked up there, and it didn't quite get picked up there, I think. I think that was because the putty wasn't quite up to the distal gingival on those second molars. But other than that, this is a great impression and obviously a great technique. So anyway, that's the putty wash technique, which you can use. You can also, use other techniques. You don't have to use the two-step if you don't want to, but I find this to be absolutely great impressions. The other thing I'd like to point out about this technique is that if you have the patient inhale, go right before you put the material in, the loose air droplets, water droplets kind of get sucked off the teeth and you get a little better impression. I take my bites almost exclusively with the airway metric system. This is a system that has been picked up by Catapult. I've owned mine for many years. The whole system is built around this snore screener. And what you do is you put the snore screener, or use the snore screener to determine how much protrusive and how much vertical the patient needs in order to stop the snoring. So you have the patient snore without this screener in there, and then you have them bite down on this thin little portion right here and have them snore again. You slowly but surely have them protrude until you find a place where they're not snoring. Then you go up to the 4 millimeter and the 8 millimeter and the 12 millimeter and check to see if they are snoring less. So anyway, this obviously is the airway metric system. You have the patient snore before you put the snore screener in. Okay. You put the snore screener in and have the patient bite comfortably. They snore again. Now you have them start protruding their lower jaw. You have them snore. They may be able to snore there, but it's a little more of a struggle. Then they snore and nothing. So you're looking at how much protrusion you have to do for them not to snore. Then you start over. They snore there. And you protrude and they have nothing. So less protrusion, but with a little vertical, you get more snore or no snoring. Now in this video, it shows as he protrudes a little more, he can snore a little bit. That's not typically what I find. I find that more protrusion does not result in more snoring. So you're obviously looking for the ideal position for this patient. Once you find that ideal position, then you go in and pick the different pieces that correspond to that ideal position. So in this particular case, I would start at about 4 millimeters and probably about an end-to-end protrusion. So here you're going in and picking the little pieces that will correspond to the right amount of protrusion. Here he's at 4 millimeters and end to end. And you can have the patient snore at those positions to make sure that you have the right position. I would caution you, when you do this the first time, don't do it on a patient. Do it on one of your staff members. because there is a little bit of a learning curve to this. But anyway, you can use the piece in several different orientations to get the amount of protrusion. You can obviously go up. That is 6 millimeters end to end. Then he takes it out, and you can go 6 millimeters with 4 millimeters of protrusion. Okay, so that's what that 4 represents. You can turn it around, and that's 6 millimeters with 6 millimeters of protrusion. So that's kind of how you size these little pieces. Obviously, he's going, in this video, he's going up and probably checking the snoring at each one of those positions. I don't find that necessary. I actually determine that in the little snore screener, because to be quite frank with you, I don't want to dirty up all of those pieces. And I just dirty up the snore screener and then go usually directly to the piece that I need. So he's determined the size he wants to use. And I'm assuming this is his 4 millimeter piece. So once he gets that done, he inserts a handle and inserts a bite fork on this this device, and goes to the impression part. You can also, there's some little bite. Here he's showing you how to insert the bite fork in the handle. Obviously, it leaves the front part open. He's using a bite registration material to take the bite. That is not how I do it. I will show you how I do it in a few minutes. I leave the front of mine totally open because I want to make sure that the patient stays in the right indentation. And but anyway, I'll show you that in just a second. Everybody has their favorite way of doing this, and there's obviously a vertical titration key. After you've made your appliance, sometimes you think you don't have enough vertical, and what you can do is actually insert this titration key after you've made your appliance and change your vertical, or check for snoring at more vertical. So here there's been a dorsal fin appliance made, and you can actually throw this vertical titration key in, check the patient for snoring. Then you can actually go in and add composite to that and change the vertical. So that's the airway metric system. Obviously, you use these little, and I call them keys. Airway metrics calls them simulators, I guess. But anyway, you determine the appropriate one for your patient. In this case, if the upper front teeth were here, the lower front teeth were here, you would have 2 millimeters of protrusion at 6 millimeters of vertical. So anyway, you pick that out, you put your bite registration forks on, and this is what it actually looks like in my office. I've got the bite fork and the handle. This is the Catapult Putty Soft. And we mix that up, and notice how I'm placing it on the fork. I am in absolute total control of that material. More importantly, I am in total control of the little key. So I can place it specifically on the front teeth and guide the lower arch exactly into the key that I need the patient in on the bottom. So it gives me a whole lot more control. This is Lindsay. She's single, by the way, 27. That's another story. Lindsay's my assistant. Here I have the airway metrics in place, and literally we massage the cheeks so the putty soft material engages the facial aspect of on the patient. Here I am doing the massaging technique. Obviously, you can tell that I am lining up the front teeth to get it exactly in the notch that I am trying to accomplish, to make sure I'm in the correct position. And this is what that bite looks like when I'm through. You can see the I guess detail that I'm getting. Obviously, it's a putty, so you're not getting the best impression. But if you saw some of the impressions that I see with bite registration material, this is a superior way to do it. You can also do this with a George gauge. Now, George gauges are kind of one of the standards in dental sleep medicine. Here you have a gauge and you have the fork in the patient's mouth. There, the fork slides in to the gauge, and you can actually measure the amount of protrusion. You can also have the patient snore with this in and try to determine, but the big difference is you have a 2 millimeter and a 5 millimeter fork. And there are some appliances that need 10 millimeters of clearance. The tap, for example, basically does. So there's very little flexibility in this technique. But anyway, you have the patient go out and in, out and in. You measure the amount of protrusion and determine from either snoring or educated guess how much protrusion you want on this particular patient. You're looking down on Lindsay again, and here you're actually seeing that I'm on 0, which for many patients that puts them fairly close to end on their front. Again, I am using the soft putty bite registration material from Catapult, and this is what that impression looks like. Again, just like the other, I do not put impression material dead on my, I guess, bite, my where my anterior teeth and on the maxillary mandibular go. I want to be able to guide that into that notch, so you get a pretty good impression that way, and obviously you're in control. Now, the beauty is that with those, there are 153 appliances that we can make that are FDA approved to treat sleep apnea. This particular one is called the Herbst appliance. I'm sure many of you recognize the Herbst bar here. It's an orthodontic bar. You've got, in this case, upper and lower acrylic appliances that are reinforced to some degree. You advance the appliance by advancing the bar. The bars come in lengths, so you have room for a fair amount of protrusion. And this appliance is approved by virtually all insurance companies and Medicare. So it is a Medicare approved appliance if the lab is approved by Medicare. The other one that we see quite often is a tap appliance. This isn't a great impression or picture of it, but you have a dual laminate system, a hard outside and a softer inside on these. These are actually fairly comfortable appliances, but they all hook right here in front. I have had a few patients that didn't do well with their arches hooked together. They kind of got claustrophobic. I know of a couple of patients that had a bridge on the front that didn't do well with all the pressure being right here on the fronts. But anyway, the TAP is also approved by most insurance companies, and it is a Medicare approved appliance. Now, if I do a TAP, I do not do it in this clear laminate, dual laminate material. That thing turns kind of a dark, dingy yellow color really quickly. So when I do a TAP, I actually do it in colors. And this is Glidewell's TAP. I usually choose the blue. It doesn't turn colors as much, and it's a little bit more appealing. So that is a very, very, very quick run through of what we can do, run through of why you have to start screening. You do not want one of your patients to have a car wreck and some attorney find out that the ADA said you had to screen and you didn't. So please, you know, do something, add something to your intake regimen that can be called a screening, not only for the protection of your practice, but for the health and safety of your patients. That's all I've got. I'm sorry that I wasn't able to go into more detail, but time did not allow for that. You can contact me at ken@dsat-sleep, or contact me at info@dsat-sleep. If you do info, if I'm down in the mouth, so to speak, one of my staff members can answer you, but you certainly have the opportunity to contact me, and I would love to help you in any way that I can. So I have one question here that says, Doc, how do you address TMJ issues that pre-exist before or during treatment, or occlusal relationships that change? If you have a retrognathic mandible, class 2 bite, do you address that first? Well, that's a whole lot in one question. Let me take them step by step. Obviously, I have a fairly extensive intake exam that I go in and I palpate basically the normal muscles that we deal with in TMD, and I go in and document clicks, pops, range of motion, lateral excursions, maximum opening, maximum protrusion, all of those kind of things. The good news is that TMD issues always get better with oral appliance therapy. If I go back 20 years to when I first started treating TMD, or not 20 years, 30 years, we were protruding everybody back then. So the point is, if a patient has fairly extensive TMD symptoms, I start off with little to no protrusion. I start off with just a little vertical, and sometimes just keeping the mandible from falling back will help the OSA. But anyway, I slowly, and the operative word is slowly, protrude. The other issue, if the patient, and this gets way too complicated, but if the patient has a closed lock on one side, usually as you slowly protrude, you turn that closed lock into a recapturing, reciprocal recapturing joint, so it becomes what I call a popper. So to go on, if the patient has a retrognathic mandible, class 2 deep bite, do you address that first? Absolutely not. The only thing I address with that is many of those class 2 deep bites, especially if they're a class 2 div 2, they're off the disc. So when I go in and recapture those discs as I protrude, many times you're going to have to deal with, and I hate to use the word dislocating the joint every morning when they get up to get them back off the disc. Question number 2. Thank you, sir, for sharing all these knowledge. How frequently and for how long will these appliances be used? Good question. First thing you need to know that most insurance companies will consider replacing the appliances after 5 years. Now, there are instances where they'll actually replace them sooner than that. Loss of the appliance is one of those. Destruction of the appliance is one of those. But you have to prove that the appliance is no longer serviceable. I've worn the appliance I've got in, or that I wear right now. I've had it almost 7 years. My wife has a Herbst appliance that she's had almost 8 years. So the appliances are really serviceable if they are a harder acrylic appliance. The tap appliances are not that, and I say that. Some of them will last, but frequently after 3 years, those appliances start disintegrating. What else? Is there a specific appliance preferred for patients with periodontal issues? First thing, we need to make sure that we control periodontal disease during this whole process. I have had numerous patients with fairly significant perio that we've treated and done really, really well. My issue with perio is how much do we have? And obviously, the more perio you have, the more precautions I take, prior to fitting the appliances. I have one patient in particular that I actually went in and splinted all of the front teeth before I made an appliance. The weight of your lower jaw is primarily being held on the lower front teeth and the upper front teeth. So you want to do the best you can to make sure that those teeth remain healthy. And with us, we make sure those patients are cleaned every 3 months and understand the what's about to happen, that pressure's about to be put on those teeth. But the hardest thing I have to deal with dentists is we're used to perfect bites. We're used to absolutely controlling perio. We're used to being worried about TMD. OSA is going to kill these people if we don't help them. I tell them, especially my patients that are really severe and the ones that I know I'm going to have to do a fair amount of protrusion to get them under control, I tell them up front, look, I'm about to move your teeth all over the place. And it's okay, because you're going to get to live to know that I moved your teeth. So I tell them it's like having open heart surgery to save your life and then complaining about the scar. So anyway, to let you know, yes, I worry about tooth movement. Yes, I worry about perio. Yes, I worry about TMD. But all of that is manageable, because if they have a stroke, they're not going to have to worry about their perio. So that's what a great consent form does for you. I didn't take the time to discuss the fact that most of the consent forms used in dental sleep medicine, I wrote them. And I have a general consent form, a special consent form for patients with significant perio. Same thing with TMD. And we deal with that ahead of time. Where am I? How often do you refer a patient to the physician, and if so, which specialty? First thing you need to know, I don't practice a lot of general dentistry anymore. So the patients that call into our office that have not been diagnosed with OSA, usually they don't come in our office. My staff actually facilitates a referral for those patients before they ever come in to see me. They send that we have 5 different sleep physicians in my immediate area, and they all refer to me. And so anyway, we facilitate a referral to whichever of those that you know they want to go to. What else? How do you get around patient complaining about the appliance being bulky? I tell them they'll get used to it. Now, not all appliances are bulky. If a patient tells me ahead of time that they have trouble wearing things like orthodontic retainers, or if they had trouble wearing a football mouthpiece, I'll go in and specifically pick an appliance that is very thin. There's an appliance named a Panthera. It's a nylon appliance that is very, very thin. There's also an appliance called an EMA, and there's a Silent Night, and a number of appliances literally that are extremely thin. And to be honest with you, I've never had a patient have a lot of problem with the bulkiness. They eventually adapt to it. Do you use a morning exerciser? I absolutely do, and you need to also. I actually have several different types that I use. The one that I universally provide with all appliances is the AM aligner, and that comes from Airway Management. The AM aligner is a thermal plastic that you heat up, mold to the mouth, and the patient ends up biting into it, and that documents their centric the day that they got the appliance. So that's the one that everybody gets. However, if this patient is one of those patients that has had adult Invisalign, and we know that they've had relatively recent ortho, those patients get, and I hate to say a hard acrylic night guard type of appliance, but it basically is, that fits their upper arch exactly. And then it has a 60-degree anterior ramp on it. That 60-degree anterior ramp engages the lower incisors and moves the posterior, or moves the lower jaw posteriorly as they bite into centric. And so those are the 2 main ones that I use. Both my wife and myself use the hard acrylic morning repositioner. The problem is that is lab fabricated, and with it being lab fabricated, there's an additional charge for that, and the patients are informed of that. Do I have the patient sign a waiver for possible tooth movement or crowns coming off? No, they don't sign a waiver. They sign a very detailed informed consent. That's different, okay? Informed consent is literally a legal document that gives me permission to do what I'm doing, and it informs the patient not only is it possible that your teeth will move or crowns will come off or root canals will fail, but it's also possible if you don't do what I say, you could have a heart attack or a stroke. So it's a extremely detailed document, and we take all of that very seriously. The next question says, do you use a morning exerciser? Do you have the patient sign a waiver? Where am I? To be used during sleep only. How about a completely edentulous patient? My answer to that is I hope you do implant. The absolute minimum number of teeth that you can do this on is a totally edentulous upper arch. You can make that work, but not well. And you can make it work if the patient has lower cuspids only. I've done that one time. The patient literally signed the consent and a release of liability saying that I'll probably wiggle her two little cuspids out of her mouth. But I've done that. That patient had an AHI of 77. I know you don't know what that means probably, but very, very severe patient who also had aerophagia. When that patient wore a CPAP, the air actually went in her stomach and she couldn't afford implants. She just couldn't make it happen. So we ended up making a custom fabricated appliance that went over her upper edentulous arch. I used a Herpes bar that attached lateral to her two cuspids, and she actually has done fairly well with it. But that is not what I would recommend. But on the other hand, if I had not done that, I don't know how long she would have been alive. So anyway, from what I can tell, I have answered most of the questions that I see. If I have missed somebody, I apologize. But the best I can tell, I have covered most of the questions. And I'm going to be at the ADA in San Francisco the first week in September. I'm doing a 2-day hands-on 2-day course there. Again, if you are in the Minnesota area, I'm at the Star of the North meeting in April. I'm at the ASBA meeting in 2 weeks in Phoenix. But anyway, at the Star of the North meeting, I'm actually going to be using the airway metric system, showing you how to use this and how to go through the different snoring sequences with the patient. We're actually going to be taking bites at that meeting. So I'm going to kind of be doing hands-on and showing you exactly what I do. But with that, I want to thank you for your time. I know I ran over just a little bit. Hopefully you can see the Catapult special. Dan Berley, if you're on this meeting, I want to thank you immensely for giving me the opportunity. If there is anything that I can do for you personally, or anything that any of my team can do for you, we're here to help. Anyway, thank you, and have a great night.